Hi everyone. This week we're going to learn about the management of ovarian cancer. Just a quick few facts and figures pertaining to ovarian cancer. It is the fifth most common cause of cancer-related death in women in the United States. This cancer mainly develops in older women. About half of women diagnosed with ovarian cancer are 63 years old or older. The rate of ovarian cancer has been declining in the past 20 years. So that's good. The overall 5-year relative survival rate is 47%. Only 15% of women are diagnosed with localized disease, and that has a 5-year relative survival rate of 92%. So that's great, but such a small percentage are actually diagnosed at that stage. Approximately 60% of women are diagnosed with distant disease, and that has a 5-year relative survival rate of only 29%. The term ovarian cancer is often used to describe cancers that begin in the cells in the ovary, fallopian tube, and peritoneum. These cancers are closely related and are treated the same way. Research studies actually suggest that high-grade serous cancer, which account for most ovarian cancer, in most cases actually starts in the distal end, the fimbriae of the fallopian tube, and spreads to the surface of the ovaries. Fallopian tube cancer was once thought to be rare, but we now know that most cancers previously labeled as ovarian cancer actually begin in the fallopian tube. Because the surfaces of the ovaries and peritoneum are made up of the same types of cells, these two diseases look alike under the microscope. So similarly to the fallopian tube primaries, it can be difficult to determine if the cancer actually started in the ovary or the peritoneum. There's one situation in which it is more easily determined, and that is when the peritoneal cancer develops after the ovaries have been removed. So then there are no ovaries, and they say, okay, this is peritoneal cancer. Just as with ovarian cancer, some peritoneal cancers may actually begin in the fallopian tube as well. The female anatomy consists of 2 ovaries, with one located on each side of the uterus. They are almond-shaped and are about 1.5 inches long. As you probably already learned in A&P, ovaries are the primary source of estrogen and progesterone. The 2 fallopian tubes are small ducts that link a woman's ovaries to her uterus. As you can see, the fimbriae, where it is believed that most of the previously diagnosed ovarian cancers began, is right next to the ovary. Therefore, you can see why it may be difficult to really determine where these cancers originated. The peritoneum, which is not identified on this illustration, is a tissue that lines the abdomen and most of the organs in the abdomen. This tissue does cover the uterus, ovaries, fallopian tubes, bladder, and rectum. A liquid called peritoneal fluid covers the tissue's surface. This liquid enables the organs to move within the abdomen and prevents them from sticking together. Since this fluid does cover the GYN organs, it can easily become involved and be positive for cancer cells. Histologic types of ovarian cancer include the epithelial carcinomas, which make up 85 to 90% of all ovarian cancers. But there are subtypes of epithelial carcinoma, which include serous, and that's the most common one, endometrioid, clear cell, mucinous, and mixed tumors. Then there are the uncommon germ cell ovarian cancers, which typically occur in women 10 to 29 years old. And then you have the stromal malignancies, which are rare. Virtually all fallopian tube cancers consist of serous carcinoma histology. As the survival rates indicated on one of the previous slides, it is important for early detection and treatment for these cancers. However, that is often not possible. There is no effective screening methods for ovarian cancer until cancer is suspected. Often women do not have any symptoms, or the symptoms do not start until the tumor is large or in a later stage of the disease. Even if a woman does have symptoms, sometimes the cancer will not be identified until a later stage because the symptoms are often very vague and resemble other conditions. Possible signs and symptoms are listed here. For many women, these symptoms occur often and are different from what is normal for their bodies. Tests that are performed to diagnose these cancers include an abdominal pelvic examination. However, if the cancer is small, it most likely will not be detected by a pelvic exam. A transvaginal ultrasound may be used to create a picture of the ovaries to identify any masses or tumors. The tumor marker CA-125, a blood test, can be done when these cancers are suspected. This marker is found in higher levels in women with ovarian, fallopian tube, and peritoneal cancers. However, women that are younger than 50 with conditions such as endometriosis, pelvic inflammatory disease, and uterine fibroids may also have an elevated CA-125 level. And this is why it cannot be used as a screening test. A CT scan is performed when a pelvic mass or ovarian mass is identified or suspected. If a woman has advanced disease at time of presentation, she may have ascites or fluid buildup in the abdomen. This may be removed with the procedure called paracentesis. A sample of this fluid would then be examined by the pathologist. If a woman has multiple abdominal tumors or seeding identified on the CT scan, a biopsy may be performed, but more often than not, a surgeon will perform surgery or at least a laparoscopic exploratory surgery to diagnose these cases. Surgical options for these cancer primaries include a salpingo oophorectomy, which removes the ovary and the fallopian tube. If both ovaries and fallopian tubes are removed, then the procedure is called a bilateral salpingo oophorectomy. Then there is a hysterectomy, which removes the uterus. Most often, a BSO, TH, or bilateral salpingo oophorectomy and total hysterectomy are performed for these cancers. If possible, a lymphadenectomy or lymph node dissection will be performed as well for staging purposes. However, it may not be performed if the patient has comorbidities or is obese. An omentectomy is usually performed as well, which removes the omentum, or the tissue that covers the stomach and the large intestine. If a patient has disease that is not confined to the organ of origin, a cytoreduction or debulking procedure may be performed. The goal of this surgery is to obtain optimal debulking, or no tumor left in the abdomen that is greater than 1 centimeter in size. A debulking may include the removal of other organs that are also involved with the tumor, such as the colon, bladder, rectum, etc. For most cases, a patient will have their uterus, ovaries, fallopian tubes, and omentum removed at the time of surgery. As discussed in the past this semester, neoadjuvant is given before surgery to try and shrink the tumor before surgery. Sometimes neoadjuvant is given before surgery for these primaries for the possibility to remove all or as much of the tumor as possible. If the patient is able to have surgery right away, depending on the histology, grade, and stage of the cancer, adjuvant therapy may be offered to the patient. The chemotherapy can be given in the normal IV fashion every 3 weeks, or it may be used in an approach that they call dose dense, which the chemo is given weekly. Some studies show that using dose-dense chemotherapy may improve survival rates compared to giving the drug every 3 weeks. Sometimes that approach is determined by the health of the patient. Some just can't go through weekly chemotherapy. The third way to give chemotherapy is to infuse it directly into the abdomen. This is called intraperitoneal or IP chemotherapy. This approach can be considered for women with stage 3 disease after a successful surgical debulking procedure. In studies, the intraperitoneal or IP treatment was more effective when compared to the IV treatment given every 3 weeks. However, studies comparing the dose-dense chemotherapy with the IP chemotherapy, they had similar outcomes. So one isn't better than the other. So it's basically usually how, what the patient can handle and the type of chemotherapy that they're given. Maintenance chemotherapy is given to reduce the time to or the risk of cancer recurrence. Avastin can be used for maintenance therapy for these cancers, which you will recall is actually an immunotherapy and not a chemotherapy. Avastin is the only immunotherapy approved for these cancers at this time. Radiation is not used as first course of treatment for ovarian, fallopian tube, and peritoneal cancers unless it is for a metastatic site such as the bone or the brain. Occasionally, it can be an option for recurrence of these cancers. Most of the ovarian cancers are the serous type, and those are graded as low grade or high grade. Other histologies, such as the endometrioid cancers, are graded using grade 1, well differentiated, or grade 2, moderately differentiated, and grade 3, poorly differentiated. The staging system used is the FIGO, or International Federation of Obstetrics and Gynecology Staging System. The AJCC T&M staging system correlates with the FIGO system, as you can see from this partial print screen of the primary tumor table. As you can see, the first column is the AJCC T category, and then the second column is the FIGO stage. Now let's quickly review the NCCN guidelines for ovarian cancer. All right, so everyone should have their account. So you just, oh, I'm already logged in here. So just mosey on down to ovarian cancer. Then we want the NCCN guidelines, all right, the red PDF file. All right, so here we have ovarian cancer, but notice that it's including fallopian tube cancer and primary peritoneal cancer. Okay, so they are all treated the same way. All right. So then, enlarging this a little. Okay, so now this is broken down by histology. So we remember how the 85% to 90% of all ovarian cancers are epithelial. So you have the epithelials and then the less common ovarian histopathologies. Okay, so you would just find the pathology that you're looking for. So this is more on pathology than stage right off the bat. So let's look at the epithelial carcinomas since those are the most common. So you have the clinical presentation, workup, clinical stage, and primary treatment. So this is what if a patient had a suspicious, palpable pelvic mass, or ascites or distension, this is the workup that the physician would want to do, abdominal pelvic exam, ultrasound, or CT, MRI. There's some lab tests that should be done, CA-125 or other markers, what's their nutritional status and things like that. And then, very important, refer to gynecologic oncologist for clinically suspected tumors. So these patients should be treated by a gynecologic oncologist because they are specially trained in cancer surgery, okay? And then they are also trained in medical oncology as well and radiation therapy. So they have a lot more training than just a normal GYN physician. And cancer-directed surgery is very, very different than a normal GYN hysterectomy. So that's very important. And then, so from that information, they would get a clinical stage, and then from the clinical stage, they would, go through the pathway, what needs to be done. If the patient is young and fertility is desired, it goes through whether it's a stage 1A or 1B, go through that. Whether it's stage 1A through 4 and the patient is a surgical candidate and, fertility is not desired, then the treatment is going to be a total abdominal hysterectomy with bilateral salpingo-oophorectomy plus staging, which is the removal of the lymph nodes and debulking if needed. If the patient tumor is just confined within, the ovary or within the ovary uterus, then that's all that. There's usually no debulking. But if there are other lesions throughout the abdomen, then that would need to be removed as well. And then the patient should also have genetic risk evaluation to see if they should have testing or not. And then once the surgery is done, they would go to pathologic staging and determine if there's additional treatment to be given for this patient or not. If the patient is a poor surgical candidate or the likelihood of them having an optimal, debulking of their tumor, then the patient would be recommended to have neoadjuvant therapy. And then the physician would just click on that, and then, once they receive their therapy, if there's a response, they could do this. If it's stable disease, then they would do more chemotherapy treatment. If there's progression, then they would go on to, therapy for persistent disease. So that's one way. And then as you can see, there's the poorly surgical candidate or low likelihood of optimal cytoreduction. If the physician knows right away that that's the case, then they can just click on that right away. All right. And then we have diagnosis by previous surgery, findings and primary treatment. So sometimes a patient will have a total hysterectomy or have their ovary removed for what is thought to be a cyst, and it ends up being cancer. Then the physician would want to click on here, and then it tells them exactly, what to do, and, they go by what is left behind or not done or things like that. And then once again, go on to do their flow and determine what treatment that patient needs. Sometimes it's additional surgery, sometimes it's not. And then if the patient, once, they were diagnosed, had their workup in the clinical stage, had their surgical treatment, and that's where the physician needs to, they can go directly to pathologic staging. And then here are the stages. And then it will say, depends on the grade of the tumor, how many, the type of chemotherapy the patient might have, and how many cycles of that treatment. All right. So then they just click, through, go through all the things and determine that. This one thing nice about the ovarian, all the stages are on one page, so that makes it nice, and then once they, do their treatment, and, there are different primary regimens that a physician can choose from. So they would just click on that to, determine on what the exact type of treatment and number of cycles. And then they would, go on to, if, they get through their treatment, then they should be given a survivorship care plan. All right. And if the physician, wants to click on that, then they can do that. Or just go to, monitoring and follow up. So a patient with stage, 1, 2, 3, or 4 after primary treatment, this is the monitoring follow-up that the patient should, be seeing visits every 2 to 4 months for 2 years, then 3 to 6 months for 3 years, then annually after 5 years. And then they tell you exactly, what type of exam should be done, what type of imaging, if, clinically indicated, as well as labs. And you'll note that they have a CA-125 or other tumor markers if initially elevated. If the CA-125 was not initially elevated, then they're not going to use it to follow up with that patient, because it's most likely not going to be elevated if they recur. And if the patient does recur, then the guidelines continue to tell the physician what should be done. So as you can see, there was no radiation in any of those treatment guidelines. So usually it's, surgery and chemotherapy, or chemotherapy, then than surgery. So that's just a quick look at part of the ovarian cancer NCCN guidelines. And just remember that these do include the fallopian tube cancers and the primary peritoneal cancers as well. So let's see. So that is it for ovarian, fallopian tube, and peritoneal cancers. Like I stated, there aren't as many treatment options or modalities as some of the cancers that we've already discussed and we'll discuss in the future this semester. However, they can, be a little more on the difficult side. They aren't always the easiest cases to abstract. So it kind of levels out, less treatment to record for, the more difficult aspect of staging and things like that. Just know that if you know that the cancer was proven to be primary of the fallopian tube or the peritoneum, and the physician calls it ovarian cancer, know that it is truly not an ovarian primary, okay, as stated earlier. All three of these cancers are treated the same, and sometimes it is just easier for the patient to understand something that they have heard about, and that would be ovarian cancer. There's not many times that you hear, oh, so-and-so has fallopian tube cancer or peritoneal cancer. Okay, so just know that, if the physician calls it ovarian cancer and it's not of the ovarian cancer, don't assign your site code, per what the physician says. Use the information from the pathology report. So if you have any questions about the presentation or NCCN guidelines, please let me know. Have a great week, everyone. And for those of you in Wisconsin and the upper states, please think spring. And anyone in the south, if you want to push up some sunshine and some normal weather, that would be great. Take care, everyone.